Hi everybody, I am just absolutely chuffed to have my learned colleague and friend, I think I'm going to call her at this point, Dr. Nicole Stout, who's really, I think, leading the global charge in terms of integrating what we know about oncology rehab and really just a more widespread prescription and acceptance of exercise as not an afterthought or an add-on, but really where it should be front and center, I think, as part of cancer treatment, both during and after. What we've learned from the ACSM guidelines that came out last year is that really movement and exercise are just non-negotiable once you've had a cancer diagnosis, because the effects of cancer treatment really take a lot of getting used to, and it's a lifelong journey. And as we've seen morbidity increase, as mortality has declined, maybe the side effects of cancer treatments have really grown. And what I want to talk to Nicole about today is how we can take those guidelines, take our expertise, take what's out there in the literature and research, and really start to bring it into reality. So Nicole, welcome. And if you could just give us a little bit of background about your journey. How did you get here?
Thank you, Michelle. I'm so appreciative of having this dialogue, and it's exciting to see literally a global movement around exercise in oncology. So a little about my background. I'm a physio by training, and I finished that training about a little over 20 years ago now, and the majority of my career has been in oncology with rehabilitation, and a lot of that has been lymphedema. Much of it has been early morbidity management through our clinical research trials looking at prospective surveillance. We'll talk about that model. And then also engaging in obviously some of the exercise community and exercise research work to better integrate that into oncology practice. And really, I think through that journey, I've had clinical roles, I've had clinical research roles, I've had research, sort of strategic research and advocacy roles, policy roles, leadership roles. And really the underlying theme for me has always been, first, how do we elevate the science around rehabilitation and exercise? And secondly, how do we better integrate into oncology care? You made the point of saying, which was a critical point, how it's not an afterthought. It shouldn't be secondary. So how do we do a better job of getting the exercise provisions up front, being consistent with that throughout cancer care? It's really been a mission of mine with exercise and rehabilitation, because we know cancer treatments will do terrible things and will diminish function in many domains. And it's not a matter of if it happens to people, it's when. So it's insufficient for us to wait until they decline when we know the majority will. So the premise that I work from is how do we assess earlier? How do we refer early? How do we manage to mitigate the decline and even prevent? And I feel like these exercise guidelines are taking us now to a new place where we can be more specific and we can be much more tangible with what the prescription looks like. Not only does that benefit us in making the prescription, it benefits patients, but I think it helps our medical oncology colleagues really say, oh, I see the evidence, I see the specificity of the prescription. It's not just this general vague, go exercise, go move more. So those are, you're spot on with saying, these are some of the important things. And then we really need to look at how do we get this better integrated into practice.
Absolutely. And I think, your paper, I believe it was 2012, looking at prospective surveillance, I feel like that really set the tone, highlighting not only the importance, but also just the financial ramifications of going down or not going down that path as well, but also in terms of quality of life and returning people after cancer to work, to sport, to exercise, to enjoying their life. They go through all this travail of cancer treatment. I feel sometimes there's almost an element of survivor guilt. I've survived cancer. Am I being greedy, asking for more, to live pain-free, to live without lymphedema, to live without fatigue or neuropathy? And I think the message that as a profession, as physios, but also fitness professionals, anybody working in this arena of women's health, no, it's not too much to ask. And I think, you know, your model of monitoring people throughout that journey, the effects of chemo and radiation are not disputed. But, you know, if we can,
Right.
if we can help people through that journey, I think it's really important. Where do you feel that as physical therapists, as physiotherapists, are we doing enough to, I almost want to say, legitimize the role of exercise, because everybody knows that exercise is good. You know, oh, go to the gym and do some exercise. Oh yeah, you can try some exercise. Can we get really specific with dosage, with recommendations, whether that means titrating up or titrating down, if there are issues, for example, with cardiovascular health?
Yeah. And you're packaging a whole bunch of things to think about there in the context you've just set for this discussion. So first, let's start with what I think of as the continuum of care for cancer treatment. And this was really, prospective surveillance started as a rehab intervention, upfront baseline assessment, prospective rehabilitation, providers doing functional assessment repeatedly throughout the cancer journey. But if we look at that model, it isn't just about the physical function. Following people prospectively allows us to monitor them for any meaningful change in cognition, in psychological status, psychological distress, anxiety, financial distress, and anticipating that many individuals will experience decline across those varied domains. Prospective surveillance is a model, I think of, for walking alongside the patient through the cancer journey, being able to identify when they start to struggle, regardless of whether it's managing their family and their kids and their finances, or managing how to move their arm and get their clothes on in the morning, how to breathe better, you know, when they're doing activities. So the idea is, we know people will struggle, they will decline. Prospective surveillance helps us be an integrated part of the plan of care from the beginning, not a side effect, not a secondary thought, and monitor those things ongoing, integrate supportive care services early. Yeah. So the point about exercise, right? And it's great to see these new guidelines, because it's really shown us that we have not just increased the volume of exercise-based evidence, the evidence-based, we've also increased the quality of the evidence that's there. We've increased the specificity of the exercise prescription with this body of evidence. And that's critical. So the first ACSM guideline that came out in 2010 gave us a very general exercise recommendation. It was more of a population health-based recommendation, which was really, it was groundbreaking at the time. And it was, it set forward the premise, first of all, most importantly, that exercise is safe, and showed that across many different populations. And I think you're right, that's a concern. Is exercise safe? Can I, should I, how much should I? And we're left sometimes with very vague recommendations for exercise. Yes, you should exercise, it's good. Yes, you should move more. Everybody knows that, but how and when and how much? So I think using prospective surveillance and this new body, the body of evidence that we've seen grow, if we start at the beginning, there is a population, there are some populations for which prehabilitation is indicated. And we have just seen some great new guidelines come out from the UK. They've done a really nice job with a prehabilitation guideline. We see Macmillan is doing some amazing work with prospective, essentially a prospective monitoring model. But the prehabilitation, really, if we look at the evidence around colorectal cancers, lung cancers, there's some compelling evidence that a prehabilitation plan of care, leveraging supervised exercise over a course of time prior to starting cancer treatments, is an enabler for those patients. Not just does it make them, does it increase their endurance? Yes. Does it increase their function? Yes. And their performance. But we've also learned that doing that has an impact on their tolerance to their treatment interventions. They recover from surgery faster. They don't spend as many days in the hospital. They don't have the number of infections that others do. They are not readmitted to the hospital. So that's exciting to see, because we can say that exercise is good for you as a person, makes you feel good physiologically is good. When we can start to take the steps to show that an exercise intervention impacts the cancer treatment intervention, that's incredibly meaningful, more meaningful. Absolutely. To our oncology colleagues, and really to medicine and health. So being able to show that we can help people become better candidates for surgery if they're not, if we increase their physical performance status, they maybe are a surgical candidate when they were not before. If we can increase their tolerability to the agents that they're going to receive. Many times when we identify individuals who are frail, who have poor performance status, we de-escalate their dose, their chemotherapeutic doses. And so they're not getting optimal treatment. Therefore, do they not survive to optimal levels? Those are great questions for the research community. So from the prehab perspective, integrating into those populations, I think the evidence base is quite compelling. Yeah. And that's a great place to start, because it sets the tone for the individual. Here's what we do as a part of treating your cancer care. You see a rehabilitation provider, you participate in an exercise program, and then we follow them through the duration of treatment. So for other individuals, we may just do a baseline assessment of their function. Mm-hmm. How do they look? How do they function? What types of activities are they doing regularly? Are they sedentary? Are they more active? But also, this is a time period where we can characterize some of those other environmental factors that impact individuals and other personal factors. How motivated is an individual towards exercise? Sedentary versus active. How do we activate someone who is sedentary towards exercise? They may not have the self-efficacy. They may not be willing to do so. And that's okay, but let's assess that at baseline and understand what we're dealing with. And then, the environmental factors. What is the built environment that people live in? What is their work environment, their family support? In the US, we look a lot at what their insurance coverage is and what access do they have to rehabilitation providers or to exercise programs. Are they going to have to pay for these things out of pocket? Do they have the means to do that? So really looking across, not just what is the cardiometabolic status of the patient? Are they safe to exercise? Yeah. But what are the treatment-related factors associated with their disease management? How do those things impact their ability to exercise? But how about the person themselves? Are they activated towards exercise? And unfortunately, sometimes people who are very motivated towards exercise, who were very active before they had a cancer diagnosis, they lose that engagement during treatment. So let's talk about that treatment continuum a little bit. And that really is, that's a place where I think we can have great impact. So people lose their engagement in exercise during cancer treatment for a bunch of reasons. First of all, they're going through cancer treatment. They don't feel well, and they're becoming fatigued. They lose their endurance, and they just can't keep up. Rehabilitation interventions, exercise interventions can help them maintain that level of endurance. The other reason some people lose that engagement with exercise is because they're fearful. Yeah. No one has taken the time to talk to them and say, you can absolutely keep golfing, hiking, rowing, biking. And so they step away from their exercise thinking, well, I probably shouldn't do that. It might hurt me.
And this tired. I should rest.
Yeah, exactly. Rest is not best. Anna Campbell says that. I will quote her. Anna Campbell will say, rest is not best. Get up, get moving. But I do think, so, I'll tell you a story about a gentleman that I worked with who had prostate cancer and, was going through continuum of treatment. He was several cycles of chemotherapy, and he was exercising, sort of working to maintain with exercise. Prior to his diagnosis, he had been a triathlete. He was doing Ironman and triathlon. So running, biking, swimming were the things that he really loved to do. And he was maintaining his level of activity throughout treatment. He finishes chemo and he About 2 or 3 months later, I see him and I said, "How are you doing?" He goes, "I'm getting back into things." And I said, he's in the pool, he's running. And I said, "How about the bike?" And he said, "Well, I'm biking at home." And I said, it's starting to get to be summer and the weather's great. And he said, "There is no way I would get on a bike right now and go back on the road. I just do not feel like I could do that safely." And that tells, I mean, what a story that tells you about the individual's level of confidence, fear that they might have. So when we dug into that, he didn't feel comfortable with his balance.
Okay.
He didn't feel like he could get on a bike and comfortably balance and integrate all of the things in his surroundings and react to those in a safe way. Right?
Yeah.
When you're on a bike a lot and in an active, like on the road, on a bike, lots of stuff is happening. You're seeing things, you're processing, you're reacting to things. Not only are you pedaling and physically challenging yourself, there's all of that other stuff. So it really told us a story about impairments that were limiting him and his confidence. So although we can say endurance training, resistive training, sometimes we've got to step back and realize there are some underlying impairments. And this is really where the physios are so critical. So for this gentleman, a little bit of cognitive impairment had surfaced, very subtle, but he was having a little bit of difficulty integrating when he was in overstimulated in an environment. And as we dug into that, he said, when I am doing activities at home and I'm trying to read and focus and my wife's in the kitchen talking and TV's on and he's like, there's all this stimulation and he couldn't focus and concentrate. So some cognitive therapies and we worked with him. We got him into, our occupational therapist who did some work with him on strategies for managing that environment. We also worked with him then on some balance strategies, static and dynamic balance exercises, strengthening his core, strengthening his lower extremities, working on proprioception, working on visual integration, to balance. So the exercise piece for him was coming back pretty easily, but the impairments were keeping him, the physical impairments and cognitive impairments were keeping him from really getting there. Yeah. So that's where I think when we talk about integrating into oncology care, it's the oncology continuum of care that we think about. When do we intercede with the patient, repeatedly over time? And sometimes there are barriers to exercise that a physio can really jump in and alleviate. Their hip hurts, their shoulders tight, their posture's terrible. They don't have good shoulder strength and stability. So those are barriers to exercise. The more that we can engage physios to improve those physical and functional impairments, then we can escalate the exercise program. Sure. So I feel like, the ideal situation is when you've got engagement with the oncology team, you've got a rehabilitation provider on board who can assess and manage those functional impairments. And then you've got exercise professionals, certified exercise trainers. We have different programs in different countries. I'm aware, different levels. I think in the UK, they have up to the level 4 programs. And we have a program in the US for certifying exercise trainers. So finding that exercise trainer or exercise physiologist who's a cancer specialist, really, and the two of you working in tandem, because sometimes the patient's going to need more of the endurance exercise and a resistive that they can give them, maybe supervised, maybe a group setting, working them towards being more independent. And sometimes that impairment's going to escalate and they're going to need the physio to get them over the hump so that they can keep doing the activity and engagement. Oh, that's exactly how I describe it. It has to be this beautiful symbiosis that we have with my exercise trainer saying, you know what, I see how he's doing this particular exercise and I see how he's compensating because, he's got tightness after a neck dissection and his scapula is not right and his shoulder isn't right. Let me have you see the physio so that you're not compensating and we can keep you on the strengthening program. And the physio sees that person for a couple of visits, gets them on a right program, and then boom, back into the gym, back with the trainer. So that I think is an ideal model. And I would love to think that is where we're moving to.
I hope so.
And and I can talk a little bit about what we are hoping to see happen with implementation of these exercise guidelines. But I'll pause there. I mean, just as I said, sort of thinking about that continuum of care and how each of these different providers for supportive care can come in and out when needed, but we're only going to be able to do that if we start from the beginning and survey them prospectively.
The whole way through. And I think, you know, that raises a really valid point that, you know, there's almost like an aggregate of burdens that a person goes through, you know, through cancer treatment. Like I'm thinking about somebody going through breast cancer treatment. So you've got essentially menopause on speed, you know, so if you're looking at controlling estrogen, you know, tendons are going to be affected, connective tissue is going to be affected, post-radiation fibrosis, chemo and all its delights as well, from peripheral neuropathy to cardiotoxicity, fatigue, balance, pain, you know, post-mastectomy pain, and then bone health issues too. And I think, you know, what you were saying is absolutely beautiful, because if we can have that continuum of care, if we can get good buy-in from the oncology team to start off with, to really underline the importance, it's not just a fluffy add-on, it's actually a really important component, core component of care. Because if you can increase someone's tolerance of treatment, I mean, we know that one of the main reasons that people don't stay on tamoxifen for the full 10 years is because of the muscle and joint issues, you know, that occur. But we can offer these, you know, these patients some really concrete steps towards resolving those issues. But then also just even in terms of preventing recurrence, you know, there's some lovely evidence out there that maintaining a healthy body weight, you know, it's all the directions, all the arrows are pointing towards specific exercise guidance and support to really look at that whole person. And I think one thing that sometimes gets left out of this whole person overview as well are the pelvic health barriers, because that's my bias as well. So what's happening in terms of bladder continence, in terms of bowel control, in terms of, you know, pelvic pain issues, particularly, you know, the example that you gave with prostate cancer. We know that obviously bladder control is huge with that population post prostatectomy. But I think for the breast cancer patients too, I think that sometimes goes under the radar. And we know that that's a barrier for 50% of women outside the cancer continuum to participating in exercise. So I think it's really important that we do keep pelvic health front and center as well, and remove the barriers to people living well. Nicole, I'd really love to get your thoughts on lymphedema and exercise, because this is the boogeyman as far as a lot of physios and exercise professionals are concerned. But what if we exercise too hard and we cause lymphedema? Can you share your thoughts on that?
Yeah, you're absolutely right. I'm happy to talk about that. That's been a hot topic for decades now. You know, we used to tell people don't lift more than 5 pounds for the rest of your life after they had had extensive lymph node dissections. And we know that we take that recommendation and throw it out the window. We know that we can do better towards enabling individuals. In fact, there are some very nice studies. Sandy Hayes has done some really nice work out of Australia. Katie Schmidt's work out of the US is pretty much unparalleled in suggesting that exercise is not only safe and good, but showing us that there can be improvements in lymphedema with supervised exercise, and really building the evidence base. Those women have built the evidence base for us to provide exercise recommendations. And a lot of that work has been done in breast cancer, but we have also seen that translated into other populations as well. So I do think there's rightfully so, there's a fear of lymphedema development. It is a chronic condition once it occurs, and once someone tips into late stage 1, early stage 2, they will have to manage that for the rest of their lives. Kudos to the lymphedema community and lymphology community around the world, because I think they have been far ahead of the curve with developing standards of care and putting those forward into best practices. The International Society of Lymphology, the Lymphedema Framework projects all around the world have been amazing advocates for bringing together the evidence and producing within country guidelines and payment schemes that have been incredibly helpful at getting people the services that they need. Our work in prospective surveillance, you cited the 2012 American Cancer Society Cancer Supplement, which was really the culmination of the prior decades' work that we had done to establish the efficacy and the evidence around that model. And the first place that we published out of our prospective surveillance model was in lymphedema. And what we found was, using prospective surveillance, early identification of lymphedema, when we just start to see subclinical changes, patient reports heaviness, achiness, we catch it early, we may be able to prevent it from going on and becoming a more chronic stage 2 and beyond. So that's a number one important premise. Identify it early. There is no such thing as a little bit of swelling. It's all important. Do not let a provider tell you, well, it might take 6 months or a year for that swelling to go away. That's wrong. Postoperative swelling does not last that long. There's a lymphatic congestion issue. If you've had those lymph nodes taken and that part of your body has swelling, see a lymphedema specialist. Well, I'll start with that. So the exercise piece. The beauty of Dr. Schmidt's work is that what she has showed us is, with under the right conditions, with a supervised exercise program, we can stress individuals in a controlled environment who have lymphedema, wearing compression sleeves. They can do resistive training. They can do aerobic conditioning. All of this, not only does it not harm their lymphedema, but her studies showed us that there's evidence that it actually improves limb volume, better control over the condition, less exacerbations, less infections. So that's a great starting place. Then the other thing that we think about then is go backwards to that patient population who does not have lymphedema. So if you are a person who has lymphedema, exercise is good for you. Exercise is beneficial. Work with a trained therapist, wear a compression sleeve, and work with them to develop a program that slowly and gradually loads your limb with an exercise program, whether it's resistive exercise or aerobic conditioning. Now, the other group, which is the more tenuous group, the at-risk. So an at-risk individual is really anyone who has gone through cancer treatment and has had lymph nodes taken. Let's be frank, everyone who has had lymph nodes removed, we don't know what people bring to the table as far as normal lymphatic function, right? Who knows what that is? We don't know what their baseline is. And so for some individuals, even a sentinel node procedure, 1 node, 3 nodes removed, will significantly escalate their risk, and they may develop lymphedema. We've seen a significant reduction in the rate of lymphedema because we are doing more conservative procedures. We're taking less nodes. So sentinel node biopsy has significantly reduced the incidence rates of lymphedema, but it has not eliminated lymphedema. So don't let anyone tell you, we only had 1 or 2 nodes taken. You'll never get lymphedema. That's wrong. We have to be smart, and we have to be aware of changes that are happening with our limb. I'll be honest with you, there is never a time that I tell a patient, do not do X whatever exercise. Do not do X activity. There are ways to prepare oneself to exercise and to do those activities. There are things that you should think about and monitor with your limb to make sure that you're not overexerting. Exercise and activity and exertion is good under the right circumstances. The set point for everyone is a little bit different. Your tolerance is a little bit different. Your limb is going to respond differently. We all have our own individual lymphatic capacity and will respond differently, even under different circumstances. On a hot, humid day, you will respond differently than you do on a cold, snowy day to an exercise program. So physiologically, there's a lot that impacts lymphatic function. So what does that mean, right? So I'm an individual, let's say I'm an individual and I've had lymph nodes removed and I want to exercise. First of all, working with a therapist is a great place to start. And beginning to stress your limb with some exercise and activity at what would be considered sort of your set point, right? If I practice yoga every day and my limb is just fine, that's a great set point. But now I say, I'd really like to, I have some friends who do this dragon boat racing, and I'd really like to get into that. Very different type of activity, very different level of activity that's going to stress your limbs in a different way. How do we prepare you for that, right? So it's sort of like conditioning program for your lymphatic system, even if you don't have lymphedema. So is exercise good? Yes, go out, take a run, take a bike, take a hike, but pay attention to your limb because it'll tell you a story. And the sensory changes can occur, feelings of heaviness, achiness, feels tight, it feels kind of tingly, your leg feels heavier. That's your body telling you a story. Even if you don't see overt swelling, sensory changes like that occur when you start to congest fluid in your limb. So, what happens, right? It's springtime, the weather gets to be nice. You've been working out maybe a little bit in the gym or in your home, and now all of a sudden it's a beautiful day and you go out for a 5-mile run when you've been doing 2 miles or 1 mile on the treadmill in your house, and you go out for a 5-mile run, 5-mile run up and down the hills and through the woods, and you come home and your leg is throbbing. You've overdone it. So those are the kinds of things to be cautious about, but don't let them prohibit you from exercise. So the wise thing to do is start low, go slow with progressing your exercise. If you become symptomatic, don't ignore it, because here's what happens, right? Your lymphatic system can take up so much fluid. And when you load it through exercise, it's going to work harder to take up that extra fluid. And as you get close to your transport capacity, your maximum amount in that part of your body, it's going to start to congest in that limb. And that's what you're going to feel. Yeah. So the feeling is telling you a story. You're close to your tipping point. So the next time you choose to exercise, step back, perhaps talk with a therapist, perhaps get a compression garment, just, an off the shelf. It doesn't have to be custom fit, just a low grade compression garment. And put that on, make sure it fits well, make sure you know how to use it appropriately, work with someone who's trained to get you that garment, and try it out with your exercise the next time. Because that little bit of increase in interstitial pressure can change all of those dynamics that caused you to have that overload. Yeah. So the sensations are telling you a story. They're telling you that you're right on the edge, even if you don't see swelling. Right? And here's what will happen. The next day, you won't have those sensations, right? Everything's gone. Oh, great. Everything's fine. Well, it really isn't, because your body, again, it's telling you the story. You pushed yourself up towards that limit. Maybe you didn't tip, but that tipping point, once it happens, once you overload significantly, that's when that protein congestion begins to really exacerbate in the limb. And then it's much more difficult to control. So if you have had lymph nodes taken, I would really encourage you, if you're an exerciser, that's great. You've learned your limb. You know what works for you. I work with individuals on racing teams, on biking, on dragon boat teams. And, some of them say, I had 20 lymph nodes taken 10 years ago and I paddle and I've never had a problem. And I said, that's great. Your body has developed those lymphatic pathways that can help to support you when you stress yourself. Not everyone's body has. So there is an element of conditioning your lymphatic system, getting those pathways. Your lymphatic system has lots and lots of alternate pathways that it doesn't use every day. So when we slowly load and progress with exercise, we help to condition the lymphatic system. So if you're exercising and you start to feel symptoms of heaviness, aching, tingling in that limb, maybe you look at it and it feels a little puffy, but it's gone the next day. Don't let that fool you. It's not just a little bit of swelling, right? That should be managed so that the next time you take on that exercise, you've got some protection. Yeah. And the other thing I'll say is it isn't just exercise, right? Because what else happens in the spring? You've been sedentary all winter. Let's say you're not an exerciser. You've been sedentary all winter and now it's beautiful spring day and you're going to go out in your garden and you're going to spend 4 hours pulling weeds, starting to, get your garden prepped for the spring. That's activity that goes above your set point also. So those are some of the things I encourage people to think about, an activity where maybe it's a spring day and you take down all of the curtains in your house and you wash them all and you're ironing for hours at a time, or you're up and down the stairs 20 times cleaning out your attic. All of those are activities that go above your set point and can stress your system. So pay attention when you're doing those things as to the extent that you push yourself to initially, right? So gradually working up into that, that's really one of the keys.
And I think, maybe another point is that you do have to have a lifelong commitment to good lymphatic health as well. Like, this is a lifelong approach, isn't it, to risk reduction? Because I've come across some women who have 3 nodes removed and they have lymphedema, other women with 20 nodes removed and no problems. But I've seen plenty of women who are maybe 10 years out, and maybe they've been out gardening in the sunshine, they had a little bit of sunburn, and then they decided to clean their windows afterwards. So it is this lifelong learning that we do have to be very respectful of our lymphatic system. And things like, constipation can really cause a flare, because if we're stagnant in around the center of our body, if we're not breathing properly, all of these things that we can have control over really, I think, can contribute to overall lymphatic health. Are you drinking enough water? Little things like that we can control a lot of controllables. There's so many things that we can't control, but there are lots of things that we can. And I think we have to seize onto those. And, it's hard to believe it's been 10 years since the PAL trial came out. And that was such a revolution. Somehow it's 10 years. So strength training, resistance training is key, really, isn't it? I mean, not only from a lymphatic perspective, but also from a musculotendinous, a bone health, and I think a mental health perspective as well. So don't be afraid to exercise with resistance.
The strength training, just a point on that, because the strength training is critical. So subsequent trials from PAL, also in women who did not have lymphedema, suggested that there may be a protective effect to having greater lean mass. So individuals who did resistive training, who had low BMI, that makes a difference, and who had who did a resistive training program, it suggests to us that lean mass may in fact be protective in the development of lymphedema. So it really makes the case for a strengthening program. Not only that, Michelle, there's this pesky thing called aging that happens, right? After cancer treatment and diagnosis, you've gone through treatment, it's a year later, you're on tamoxifen or Arimidex for 5 years, 8 years. You age during that time, right? So age-related senescence, decreased bone density is a real thing. Weakness in the pelvic floor is a real thing. Those things happen with age. And many times they are magnified by the side effects of cancer treatments. We look at some of the evidence around the use of anthracycline chemotherapies, trastuzumab or Herceptin, and the cardiotoxicity. They call this, it reduces cardiac output during treatment, and ejection fraction is falling. And they say, women who experience about a 25% reduction in ejection fraction after getting an anthracycline drug and Herceptin, and their cardiac age is essentially 10 years older than their actual age. And so the aging piece of this we cannot discount, mostly because our population is aging first, which is increasing, their risk for cancer. Second, the second piece of that is our population of cancer survivors over the next 2 decades, the majority of them will be over the age of 65. So we have got to think about whole person when we're thinking about exercise, because you're right. How much is incontinence playing into this? How much is decreased visual acuity playing into some of the deficits that they're experiencing? So being able to exercise and be optimally physically active is critical. And how do we prevent those impairments, those other issues, from interceding and preventing us from being as optimally active as we can be?
Absolutely. It's vital. And I think, the biopsychosocial is a little bit of a buzzword in our profession these days.
Mhm.
And
Mhm.
I think, I'm also seeing a trend in the world of physio as well, to almost for a lot of practitioners to step away from manual therapy and to integrate, pain education. And all of that is incredibly important, obviously, from a fear reduction and a stress management perspective.
Mhm.
I think manual therapy and exercise prescription though really do fit in nicely under this biopsychosocial umbrella, perhaps nowhere as much as they do in oncology rehab, because to be able
Yeah.
to put your hands on somebody and decrease that pain response, that stress that can really turn up the volume, I think it's really important as a profession we don't lose that. But I think, for all the reasons that you've talked so eloquently about, I think as a profession, we could up our game a little bit in terms of exercise prescription, being a little bit more specific with dosage and intensity, and to monitor, to really get tuned into, as you said, that specificity effect as well, because I think that's going to lead to it being taken a little bit more seriously, perhaps, by our oncology medical colleagues. Do you feel there's been a move towards that? I know that the evidence is there, but I'm wondering, are you seeing that translating well into clinical practice? Is there good buy-in from the medical oncology community into exercise adherence? What can we do better?
Yeah, that's a really great question to tee up the next part of this conversation. I think what the new ACSM guideline has given us is a level of specificity in exercise prescription for some of the most common impairments that we see across cancer types.
Mm.
So fatigue and lymphedema and bone density. There's more specificity in this guideline. If you haven't taken a look at the guideline yet, Kristen Campbell was the lead author. Carrie Winter-Stone was the second author. You can find it in Med Science, Sports, and Exercise. It was published online. There you go. It's accessible to you for free. You can access it online for free. So the specificity is important, because here's where our medical oncology colleagues, many of them, are right now. I know exercise is good. I try to encourage my patients. I don't know what to tell them to do or where to go.
Yeah.
And we had a woman speak. She was an individual who had a history of multiple cancers, many surgeries, and she spoke at the ACSM roundtable. And she was an exerciser, avid, and she said, the worst thing my doctor told me was, yeah, you could probably exercise, but don't overdo it. And so giving her license to say, yes, you can, but at what level, at what frequency? Exactly. That's almost worse. So I feel like we're at this point where our docs are saying, yep, it's important. Yep, you can do it. Well, but just don't overdo it. And in the absence of specificity that we now can offer, they're making people even, a little more wary. So I think it's critical to integrate with your rehab providers and your exercise specialists, because they know the specificity with which they can prescribe exercise. And the evidence is interesting when we look at moderate intensity versus low intensity. In some individuals, resistance training may be more appropriate. As you mentioned earlier, weight-bearing exercises, if we're concerned about bone density, which we are in our breast and prostate cancer survivors who are on prolonged hormonal therapy. So our prostate cancer folks, they're losing lean mass at a ridiculous rate. So resistive training, weight bearing exercise. So the guideline can help to give us that level of specificity around the exercise. But the other piece of this I still go back to is the importance of impairment management for these folks, to make sure that the impairment is not the barrier to them exercising. And your point earlier about pelvic health and pelvic floor, this is another place where there's great evidence that prehabilitation, a course of care to teach biofeedback and Kegel exercises, helps to restore continence more quickly in our prostate and our gynecological cancer survivors. So it isn't just issue a recommendation for exercise, moderate intensity, 2 to 3 times a week at whatever the guideline specific prescription is,
Yeah.
but it's also contextualizing what else needs to be managed.
Yeah.
I'm hard pressed to ever find a woman who has breast cancer related lymphedema that doesn't also have some shoulder issues, some postural issues, a little bit of breathing deficits that we can't remedy. So looking at sort of, as you said, the aggregate burden of impairments that these folks experience. So it isn't, in my opinion, and I think in those of us that worked on the ACSM guidelines, these new guidelines, we're now looking forward and saying, great, we published a guideline. Pat yourself on the back, and now what's next?
Yes.
What's next is we must move to implementation. We must show people the pathway forward as to how they can implement. So kudos to the ACSM. What they have done now is decided to support a new initiative called Moving Through Cancer. So you may be familiar with the Exercise is Medicine initiative from ACSM, and a lot of great tools and resources around Exercise is Medicine. As a subsidiary part of Exercise is Medicine, we are now kicking off Moving Through Cancer in 2020. You can already go and Google that and look on their website. First of all 3 of the papers that were published are there for you to access, but there are also a bunch of other tools. There's a really nice prescription pad that you can take for your oncologists to have and give them a tool to make it easy, right? They need the easy button. They're busy, they're stressed, their clinics are crazy, their advanced practice providers are crazy, their nurse practitioners. They need something simple. Check off the box, and how do I get the person then to the right exercise program? So Moving Through Cancer is working right now. We have a core steering committee, and we are working on a strategic plan for implementation practices. And that will involve a registry. You can go on there right now and you can click on, and if you have a cancer exercise program, if you are an exercise specialist, contribute, put your name in there so that people can find you. That registry will be a phenomenal resource to individuals around the world to find the cancer exercise programs and exercise specialists. So that registry is live right now. You can go and click on that and you can put your name in there and become a resource. The second thing that we're working towards is regional conferences so that we can start to push out and talk about implementation models for this. It's one thing to just say, here's the evidence, here's how you should prescribe exercise, but how can we engage around the country, around the world, where people are doing have implemented the models? What best practices work for them? How do we translate that? And basically, how do we bottle it up and spray it all around for everyone else? And this is what we're trying to move towards, hopefully with some of these conferences, these implementation conferences in the next few years. We're also looking at policy initiatives. How do we improve awareness among policymakers so that in your workplace, when you get a cancer diagnosis, your employer develops a better understanding of what your needs are. Your insurance payer has a better understanding of supportive services that you need. A financial planner has a better understanding of how they can support you through that journey. So identifying where the policy needs are to help to improve payment for wellness programs, reimbursable services with exercise. How do we better integrate that? So the policy piece is a big aspect of this as well. And then also we're looking at how do we take this and catalyze the next generation of research? Because what we have now is, it's great, but it's now. How do we get even more specific? And I think if we're really forward looking, we can see there have been some great articles, commentary articles, and preliminary research that we've seen from Dr. Lee Jones and his group at Memorial Sloan Kettering, really saying, hang on, let's take a step back here and let's look at mechanisms, because we don't have good mechanistic research around exercise and its influence on the tumor microenvironment, tumor vascularity, and those are things that may change the way we treat cancer patients with exercise. Now that's the future looking.
Exciting.
But those are, we've got to start to catalyze research in that direction, not just to show that exercise is good and exercise improves endurance. Does it impact the disease? Does it impact the patient's survival? Does it impact their tolerance to treatments? Do they have less hospital stays? Do they have less toxicity with their treatments? So really looking at how does this impact the cancer continuum? Does it change it in a positive way? So that's the forward-looking implementation piece of this. It's not good enough for us to say, yep, we published this, go take a look at it, read that great paper, pat ourselves on the back, woohoo.
Well,
We have basically said it's not good enough. We now need to push it out there and encourage people to take it up.
Well, I am going to pause and give you a pat on the back, because it is a great paper, and I think it has moved the conversation forward tremendously, those 3 papers particularly. I wonder, one of the things that I was kind of thinking about looking at those 3 papers is that they were very much categorized by cancer, like breast cancer, colorectal cancer. And I'm wondering if there's any move on to actually maybe start looking at grouping by symptom, by fatigue, by cardiotoxicity, by neuropathy. You know, is that a direction that you see emerging at all, or not?
Yeah, so the nice thing, the prevention paper, the first paper that Alpa Patel led, Dr. Patel's paper, with regard to prevention, really was focused on the specific types of cancer for which exercise evidence suggests that we reduce the risk of developing cancer. So that was very focused on those specific types of cancers. The reason for that is when we do these big prospective observational trials, we do them and we categorize what kind of cancer do they have. And that's how we break out and we look at our results. The second paper by Dr. Campbell looked more at that broader impairment base, right? So that paper broke out the evidence for fatigue, the evidence for CIPN, the evidence for bone density. So looking more broadly across populations, one of the challenges that we have is enrolling patients into these trials and creating trials that are broadly representative of the cancer population. So one of the things that we're starting to see, which is encouraging, the FDA is starting to, in the United States, is starting to approve drugs not necessarily within a specific cancer diagnosis. So some of the newer immunological therapies are relevant in a specific mutation. They target a specific mutation of the cancer. That could be a variety of different types of cancers. So we're starting to see more research around what they're calling tumor agnostic trials. And I think this is, looking forward, this is where we need to go, right, with looking at our exercise interventions, regardless of whether it's pancreatic cancer or colorectal cancer. What is the end point? How do we control for? How do we implement an exercise regimen and look at some of those, the impact of exercise on the treatment? I think we're going to be challenged to do that because different cancer types have different treatment interventions, which bring different side effects. Varying severities of cancer diagnoses. Stage 1 patients look very different than stage 4 patients, even within the same disease type. So we're challenged there. I think there's always going to need to be an element of characterizing the type of cancer, understanding the chemotherapeutic agents, the immunological agents, and understanding how exercise has impacted those side effects. But I do think we've got to start looking at broader populations beyond just our usual suspects, right? Breast, colorectal, lung, and prostate. And we're starting to see that. There's been, even just recently in the last few months, some exciting translational research using exercise in pancreatic cancer, looking at the tumor microenvironment and looking at that increase in blood flow to the tumor actually slowing the growth. So we had seen that in mice. Just back in September, I saw a paper that has shown that translates to a human subject, to human models. Wow. And so hopefully we're going to continue to see, and again, that's pancreatic. That tumor type may react a certain way that another tumor doesn't. So I think we are always going to have that element of cancer-specific exercise interventions. And maybe not. Maybe it all makes a liar out of me in the future when we say, anyone that has this type of gene mutation gets this kind of exercise intervention, right? Maybe that's the future, and that's ideal. that we're able to get to that level of specificity, but I think we're a ways off. But I don't, I think the caution for folks listening is this: when you see something published in the breast cancer literature or in the prostate cancer literature, I don't know that you can necessarily say, well, let me take this over and implement it in my non-Hodgkin's lymphoma patient population. I think there needs to be adaptation and tailoring of that exercise prescription. We definitely have some evidence around exercise interventions and exercise prescription in those populations. So we have to think as therapists. We have to synthesize what we see in front of us. We have to make clinical decisions based on how the patient presents. There is no one size fits all. No. And if you're looking for that, you're looking in the wrong place and you're in the wrong field maybe, but there just is not a one size fits all in this.
No. Nicole, I could literally just sit here and listen to you all day because you are just, I mean, the pearls of wisdom just keep on coming. But I am aware that you probably have, you know, other things to do with your time. I cannot thank you enough. I mean, I've said it before, I think you're very much a global leader in this field. And I think you've done so much to bring our profession forward and to really elevate the role of exercise prescription in the field of oncology. So, you know, on behalf of the planet, I'd like to thank you for that. Where can people find you? I mean, Twitter, I think, is normally where you like to hang out. What's your handle there?
It's at Nicole Stout PT. And I do like to hang out on Twitter. I very much use it for evidence dissemination. Sometimes you'll get some food pictures from me. I'm not a dog or cat owner, so you're not going to get that. But I really do enjoy engaging in with the oncology and the exercise community on Twitter. There are some really phenomenal individuals in exercise oncology. That's a great hashtag to follow. Hashtag Cancer Rehab is another great Twitter handle or Twitter hashtag to follow. And you can always email me. You can find me. You can find me on LinkedIn, and please, I'm always happy to be a resource to help to support folks. And to your comment about global, it truly is. It's a global community, and we would not be where we are right now if it were one person. We have such an amazing community, and Katie Schmitz has done an amazing job in leading this ACSM initiative. We have participants. Anna Campbell has participated and is on our Move Forward task force, our Moving Through Cancer task force. Anna Schwartz, Sandy Hayes from Australia participated. We've had folks from the Netherlands. We've had Martin Stuver from the Netherlands. We've had Morten Quist from Denmark. We have, I mean, there's just, and I'm being remiss in not naming all of the wonderful people who have participated in this and have really brought this forward. The reason it is so successful is because we have that global community. And so kudos to those individuals for stepping forward. And really, this was a Herculean effort. The time that we have all put in, the effort that we have, because we're passionate about this. And we see the value of it in bringing this evidence forward. So thank you, Michelle. It's been great chatting with you. I so appreciate the opportunity to spread the word. So thank you. Thanks.
Amazing, amazing. And again, thank you, and hopefully see you in Copenhagen in a few months.
I will be there, of course. Absolutely. I can't wait. Copenhagen in May. I'm just delighted. It will be extraordinary. So if you're not familiar with what that is, folks, it's the ICPTO. It's the International Conference for Physical Therapy in Oncology. It's our second conference. The first one brought in over 250 individuals from almost 30 countries. Wow. So, and it's all oncology, physiotherapy. It was an amazing, amazing event. And we're expecting this to be even bigger and better. So please come. I'm speaking. Lee Jones will be there speaking. Martin speaking. Kristen Campbell. I mean, we've got all of we've got the global leaders there. So come and hang out with us in Copenhagen. It'd be great to see you all.
Beautiful. Yes. On that note, thank you again, Nicole, and have a great rest of your day.
Thank you. You too, Michelle. Thanks so much.